First of all, I would like to welcome our chief guest, Dr. D.K. Sharma, Medical Superintendent, AIIMS Delhi. Welcome, sir. Thank you for sparing your precious time and accepting our invitation. I request Ms. Sonali to give token of love. Please, someone take photograph. I welcome guest of honor, Mrs. Nirmal Kane, Nursing Superintendent, AIIMS Delhi. Welcome, ma'am. Thank you for being here on this auspicious day. I request Ms. Rosmi to give token of love. I welcome organizing chairperson Dr. Lata Venkateshan, Professor cum Principal, College of Nursing, AIIMS Delhi. Welcome, ma'am. Thank you for joining us. I welcome Dr. Kamlesh Sharma, Associate Professor, College of Nursing, AIIMS Delhi. Welcome, ma'am. Thank you for being with us. I request Ms. Surya to give token of love. I would like to welcome Dr. Shashi Mawa, coordinator of this workshop, Associate Professor, College of Nursing, AIIMS Delhi. Welcome, ma'am. Thank you for guiding us throughout the planning and preparation and being a good mentor. I request Ms. Shruti to give token of love. I welcome Mrs. Monica Sabarwal, Tutor, College of Nursing, AIIMS, Delhi. Welcome, ma'am. Thank you for your guidance and support. I request Ms. Seema to give token of love. I welcome Mrs. Suman Dabas, Tutor, College of Nursing, AIIMS, Delhi. Welcome, ma'am. Thank you for guidance throughout program planning. I request Ms. Neetu to give token of love. I welcome all other faculty members present and in their absentia for the workshop. No program is possible without participants. I welcome all the participants for this workshop. You are the essence of this workshop and your active participation is required to make the workshop a great success. Hearty welcome all of you and my colleagues who are working hard to make this workshop a memorable one. Now, I would like to invite all the dignitaries for lamp lighting. Please start Saraswati Vandana. They can be seated. One representative from PC, please come.
Clap, please.
Now, I request Dr. Shashi Mawa ma'am to address audience, share the objectives and theme of the workshop.
A very good morning to everyone. Respected Dr. D.K. Sharma, Medical Superintendent AIIMS, Madam Nirmal Kain, Nursing Superintendent, Dr. Kamlesh Sharma, Associate Professor, College of Nursing, Madam Monica and Madam Suman, and my other colleagues as well as participants and dear students. We have thought about planning in-service program on infrastructural planning. And this is a very important area for administrators, not only for medical field, but even for nursing fraternity. So the topic chosen is very apt for nurse administrators, and that is the reason we have chosen the nurse administrators to be attending this workshop, because they are usually involved in the planning and designing of hospital infrastructural things. So the intent of this workshop is basically to sensitize you regarding the hospital norms. What are the norms which we should be following through while we are planning, and when it should be done, how it should be done, and also to provide information related to infrastructural guidelines, specifically on disaster prevention. We need to incorporate the disaster prevention guidelines while we are planning for infrastructural building norms. Then another objective is to design how to design an ICU, an emergency, how to design a ward, and the specific critical areas. What should be the points to be kept in mind while we are designing those, and if at all, like we have planned everything, but if at all any disaster occurs, what should be our disaster evacuation plan also? We should be knowing at the planning stage itself. So with this, these are the objectives, and I expect that all of you will be able to learn something during the sessions which we are conducting. We also have an exercise session at the end regarding which we are going to involve all of you, that how we will be designing an ICU or an emergency at the end of the workshop. Then the theme of today's workshop is, anybody knows what is the theme? It is already disclosed. So that is the topic. What is the theme? Think ahead and be prepared. So we need to think in advance so that we are prepared for the future. So with this, I welcome all of you once again, and a happy learning to you. And I hope you are going to enjoy these few hours of learning with us. Thank you.
Thank you, ma'am, for your motivating words. Now, I would request Dr. Kamlesh Sharma, Associate Professor, to address the audience.
Respected Medical Superintendent Sir, Professor Dr. D.K. Sharma, Dr. Lata Venkateshan, our Professor cum Principal, College of Nursing, AIIMS, Madam Nirmal Kain, Nursing Superintendent, AIIMS, Dr. Arun, AIIMS New Delhi, Mr. Deepak Venkatesh, Shri P.K. Rao, who will be the speakers of the day today, all the organizers, organizing secretary, organizing team, and dear participants, and of course the post-basic BSc nursing students who are actually behind organizing this particular workshop. Now, first and foremost, why do we have these workshops?
In addition to what Madam Dr. Shashimawar has said, that what you will be learning during the day, this exercise from College of Nursing is supposed to be teaching, educating our post-basic nursing students or even MSc nursing students how to organize such events. Tomorrow they are going to be in these places or as educators or managers or administrators, so they ought to learn how to organize these in-service education program. So towards this end, we have about a series of about 10 workshops this time. This theme or this topic that has been aptly conceived by our able principal ma'am, and now throughout all these 10 workshops, different aspects are going to be taken up for the learning of the nursing officers or the nurse managers of different levels according to their requirements. I think it would be an understatement to say that how important this is. As Madam has said, that this is something that we need to be prepared for. Very often we see that things happen and then we try to plan and work out things reactively. Even a small fire is there and then we try to find out what could have been done. There is some mishap in the hospital or in the other administrative area, and then we try to find out what is it that we could have done. Recently, I'm sure you have had this first-hand experience of COVID, the big emergency that everybody had to take note of. Before that, we had some fire in some of the units, some academic wings of the institute as well, and then we tried to think about what more could we have done. So instead of thinking reactively, we need to work proactively. How we can design these areas, what infrastructure is required so as to prevent such mishaps or to handle these more effectively and to reduce the damage that generally happens. So towards that end, I must congratulate the organizing team, the chairperson, the secretaries, and everybody else who have been working tirelessly to make it a learning experience for all of us. I'm very thankful to our chief guest, Dr. D.K. Sharma sir. Actually, he's more of a family than a chief guest. I do not know. Pardon me, sir, if I say so, because for every event in the college, we know that if nobody else is there, sir is there, and very often even in the cultural program, sir and his family. So we always take it as a given that we have our family there. So thank you so much for your support and encouraging the students every single time. I must thank Dr. our CNO Madam, Dr. Kamlesh Chandelia, who always supports us in organizing such events, and Madam Nirmal Kane for readily agreeing to be the guest of honor today. And you have today a very fine line of speakers who will be deliberating and very practical points with you. My only appeal to all the participants is please take active participation in all the discussions and deliberations. And this is not one-way learning, it must be two-way learning for everybody. Okay? You have your strengths, you know the issues at hand, you have faced that in recent times, so do not hesitate to discuss those and to deliberate on the same. So with this, I would not like to stand in between the students or the participants and the learning experience today. So thank you everyone once again.
Thank you, ma'am, for your inspiring words. Now I request Mrs. Nirmal Kane, Nursing Superintendent, AIIMS Delhi, to address the audience.
Good morning, respected Dr. D.K. Sharma, Medical Superintendent, AIIMS Hospital, Dr. Lata Venkatesan, Principal, College of Nursing, Dr. Shashi Mawar, organizer of the program, and the other faculty member and dear participants. It's my pleasure to be here with you on inauguration of this workshop on hospital infrastructure planning and designing organized by College of Nursing. Hospital infrastructure planning is an essential part of clinical nursing administration and it should be on top priority. It is an opportunity to attend workshop on infrastructure planning and designing. We need to have updated knowledge and adequate skill to provide quality patient care. As nurse administrator, we have to plan and design wards and units. By participating in this workshop, nursing administrator will increase their knowledge. I congratulate the principal, College of Nursing, the faculty member, and student, College of Nursing aims to organize these kind of workshops. Thank you. Happy learning. All the best.
A heartfelt thanks to you, ma'am. Now I request Dr. D.K. Sharma, sir, Medical Superintendent, AIIMS Delhi, to say words of wisdom.
Thank you. Fellow dignitaries on dais, Madam Nirmal Kane, Dr. Kamlesh, Dr. Shashi, Ms. Suman, Ms. Monica, Principal College of Nursing, I believe is available online. Dr. Arun, my colleague who is present here, participants of this program, ladies and gentlemen. First of all, I would like to compliment the College of Nursing that the college is fulfilling its responsibility of imparting education and training in the right way. That one, through formal educational programs, imparting degree of BSc honors, BSc post basic, then MSc in various specialties, and besides these formal degrees, the college is also conducting several workshops, training programs, symposia, conferences, thereby imparting knowledge, wisdom, and training to the participants. And today's topic, hospital infrastructure planning, with the theme of think ahead, be prepared, is indeed very important. There is a basic dictum in medical sciences, prevention is better than cure. So that applies here also. That if you can think ahead and plan and prevent something, it is much better than treatment. So you have to think of how to go ahead with the infrastructure planning so that your processes can be according to the given norms and the outcome will be the best possible. Here I would like to talk about two basic principles in management that we teach our students. One is input, process, output, and second is form follows function. So input, process, output model says that first of all, you have to see that your input to anything is right. Then you have to follow the right processes and thereby the outcome is going to be right as you desire. So here, what I am talking about the input. In input, we can talk about physical infrastructure, manpower planning, money, the equipments and everything. So here today, we are talking about infrastructure planning. So if our input in terms of infrastructure planning is good and we follow right processes, so the outcome, that is good patient care services, is going to be indeed ensured. Second is form follows function. This is true in infrastructure. That means you have to think of various functions that the facility is going to provide beforehand and accordingly design the infrastructure. Because otherwise what happens quite often is that some building is made and you are asked to use it and then you end up thinking that how to use this particular room, how to break the wall, how to do this thing, how to plan evacuation in case of disaster and all those things. So basically functions have to be decided first and then only the form should come up. This is a basic essence of infrastructure planning. And this is very, very important when we talk about emergencies and disasters. Because one, the emergency and disasters ought to be prevented as far as possible, but there are certain things which are not in our hands. So for that, we have to be well prepared. That means if we are planning the emergency department, where it is located, how the patient will be received, if there is a disaster, there is an increased load, so how will they be disembarked from the vehicles, how will be taken in, where they will be triaged. given preliminary treatment, shifted to proper areas. So all those things, if you are able to think ahead, only then you can advise that this should be planned in this particular way, and that is how your infrastructure, good infrastructure, would come up. And that is what I believe is going to be taught to you today. And I'm sure that the knowledge gained by all of you during today's deliberations will be indeed very helpful to you when you go back to your respective places and start working as nursing officers. And I'm sure that the learnings with today's program, as well as all other programs that the college has been conducted, is going to give you knowledge, wisdom, and experience to deal with various situations. I wish the program a great success. Thank you.
Thank you, sir, for your motivating and inspiring words. I request Mrs. Suman Dabas, ma'am, to deliver vote of thanks.
Thank you. So, good morning, all the dignitaries on the dais and dignitaries joining online, and their participants who are attending physically, and the participants who are attending it online. So, it is my privilege to propose a vote of thanks on behalf of chairperson, coordinator, and organizing team of today's workshop on infrastructure development and planning. So I would like to express my sincere thanks to Dr. Randeep, our director sir, Dr. Randeep Guleria, for permitting us to conduct this workshop. And I must mention the deep sense of appreciation to our distinguished chief guest, Dr. D.K. Sharma, medical superintendent, AIIMS New Delhi, for his esteemed presence and always supporting us in our programs, and for his words of wisdom. Thank you so much, sir. And I would like to express pounding thanks to our CNO ma'am, Mrs. Kamlesh Chandelia, in her absentia, and who always support us in providing the participants and in all the logistics while conducting these programs. I thanks to Mrs. Kamlesh Chandelia, Chief Nursing Officer. And I would like to thank our guest of honor, Mrs. Nirmal Ken ma'am, and Nursing Superintendent, AIIMS New Delhi, for supporting us and accepting our invitation, and for her esteemed presence. And I extend my sincere thanks to our principal ma'am, Dr. Lata Venkateshan, in her absentia, for her unconditional support, encouragement, and guidance throughout the program, and always providing us all the support. I would like to thank our Dr. Kamlesh Sharma ma'am, Associate Professor, College of Nursing, AIIMS New Delhi, in providing support throughout the program. And I would like to thank Dr. Shashi Mawar, coordinator for today's program, and for her constant support in organizing the program, coordinating these events, and arranging all the logistics for this program. Thank you so much, ma'am. I thank the organizing team, Mrs. Monica Sabharwal, Tutor College of Nursing, in organizing this event, for her constant support and tireless efforts in arranging today's event. I would like to thank all the faculty from College of Nursing for coordinating their efforts in organizing. I would like to thank post BSc Nursing second year student for their tireless and united efforts for organizing this event. And I would like to thank all the speakers, eminent speakers, who will be sharing their knowledge in this event. I would like to thank all the participants who are joining here physically and who are connected with us online. And I thank all the staff of CMET for all the technical support and arranging all the logistics required to conduct this program. Thank you so much. I would like to express my sincere thanks to AIIMS Cafeteria for providing food for this program. And in the last, if I forget anyone name, I am thankful to each and every person who are continuously working behind the scene for making this program in real situation. And thank you everyone, and have a wonderful learning experience. Thank you so much. Now we will disperse for the tea break. We can join in pantry, which is at the entrance time.
Ma'am, can we start? Can we start? Welcome back, everyone. Now, I would like to invite Dr. Arun Verma, Senior Consultant, Project Management Unit, AIIMS, Delhi. Sir is going to share his expertise on overview of hospital designing as well as infrastructure guidelines for disaster prevention. Over to you, sir.
Thank you. Good morning. First of all, sorry. Morning, madam. First of all, I like to congratulate all of you for organizing this workshop and like to ask basically, I'm not the firm believer of these kind of workshop unless or until these are the bi-directionals. Okay, we will keep this interactive session and wherever it is possible, you can ask the question in between and at the end of the session, we will discuss all the things basically. So let's start. Overview of the hospital building norms. So to start any of the project, you have to fix the guiding principles for the project. Am audible? Okay. So for the guiding principle for the hospital planning, you have to fix the clientage. So what kind of population you like to serve, basically urban or the rural, or the what kind of facility you are planning, basically the primary level, secondary level, tertiary level, or so-called the quaternary level. So your planning of the hospital is according to the services or the clientage you are going to serve. Secondly, the what kind of patient you are willing to take, critical patient, normal patient, or moderate to severely ill, or the ultimately critical. If you are planning for the critical patient, we have to plan for the ICU beds. Otherwise, we can have the HD or the normal general beds. We will share the presentation, not a problem. Then the knowledge of the specific technology. If we have to align our thoughts or the planning process with the available technology. If we are having we are planning for the CT scan, MRI, or the modern diagnostic or the laboratory techniques, then we have to fill the guidelines or the required criteria for the fixing of such kind of facilities. If we are planning for the MRI, we have to keep thinking around the 80 square meter or the 80 square meter road for the planning of the MRI and associated services. Like we have to plan for the helium gas chamber for the MRI. So the basic requirement to fix the facility in the hospital, we have to keep the guidelines open. Then we have to go through the architectural factors. Sometimes the plot available for the planning of hospital is not the rectangular or the square shape, or you have to plan the linear or the non-linear type of the buildings. Linear is basically the rectangular shape building or the L-shaped building or the square shape building. Sometimes due to the architecture factors constraint, you have to plan the non-linear buildings such as the spherical shape building or the irregular L-shaped, M-shaped buildings or the curvy linear type of the buildings. Basically, if you are planning the curvy linear buildings or the spherical or the circular type of the buildings, there is the most of the dead spaces which come inside the hospital. Basically, in the square shape, you can fix a bed or you can fix a facility. But if the building or the floor area is the curvy linear basically, and you have to place your bed or the services on the periphery, then the square shape area and the end of the bed area basically that become the dead space and increase the infection control, infection rates in the hospital. Then there are some design consideration for hospital building. What is the structural consideration to accommodate current or the future needs? Basically, sometimes when we are planning, there is the budgetary constraint, or you have to start the hospital with the initial budget. Suppose we have the 100 crore budget for planning a hospital. By the end of the planning or the end of the construction, at the time of commissioning of hospital, all the budget is gone. So you have to start the hospital within that constraint. So if you are planning the CT scan, MRI, or the advantages or the high level of the planning structure like the super specialties, OT, hybrid OT, robotic OT, so-called whatsoever it is. So you have to first initiate with the normal or the basic investigation like the hematology investigation, like the X-ray, not the CT or not MRI. For the future needs, we have to plan. So many of the hospital we have seen there is the expansion later on. If you are plan a building today and your requirement down the time, basically 5 years later, you have to plan an MRI. You can't put an MRI in that building if we planned 5 years before. There's a theme for today is the basically the think ahead. You have to think five years or the 10 years down the line. If you are requiring such kind of techniques, such kind of diagnostics, or the such kind of lab investigation in future. Basically, if you are planning to have the MRI or a CT scan down the line of the 5 years or the 10 years, then you have to plan accordingly. Basically, for these type of diagnostic, you have to need around 100 square meter to 150 square meter of area. And if the hospital premises is small or the not sufficient for having such kind of area, we can't plan. So we have to think ahead. Then the electrical and the mechanical consideration for the current and the future. As per the general norm, basically one patient bed consumes 3 to 5 kilowatt hours. In layman's language, basically 5 units per hour per bed. If you are planning at 100 bed hospital, then you have to think around the 500 units per hour. Basically, is the consumption for the hospital. It's a normal hospital, not a super specialty hospital. So the electrical load we have to capture accordingly for the basically a planned bed space. And accordingly the water requirement is basically in the tune of 400 to 500 liter per bed per day. So the storage of that kind of water, availability of water, and in case of electrical load, you have to plan sometimes. If you are planning more than 200 beds of a hospital, you have to plan electrical substation within the hospital premises. So basically the requirement and clearances from the local municipal corporations and the electricity boards, which are supplying so much of electricity is available for that hospital, or so much of water. And if water is supplying to the hospital, then after the consumption, the water becomes basically the treatable or the non-treatable. Then accordingly the ETP and the STP facilities to be planned. So ETP basically where the chemical waste is coming out from the labs, the waste water is going to the ETP. And from the general sewerage or the general washrooms, the water goes to the STP. So we have to plan the ETP and the STP accordingly. Then the adequate space for the provision of patient care and unhindered maneuvering. Basically, sometimes what we have seen in the ward, sometimes patient collapse inside the ward, and you have to intubate the patient in the ward. You have to move the bed, but there is no space. You have to intubate the patient, you have to come on the head side of the patient, and first you have to basically move the bed to the leg side of the patient to come the doctor or the assistant or the nursing to the head side of the patient, but there is no space. So the golden 45 seconds or 1 minute are wasted to get the doctor or the anesthetic or the intubation, whosoever is done, to come on the head side. So basically we have to plan accordingly. If we are having the such kind of patient which might require the intubation or the critical care support, we have the enough bed space on the head side or the leg side so that we can move the bed. Then the destination points for the patient. Basically how the patient come in the hospital. What are the starting points? One is the OPD, one is the ED, emergency, and second is the directly patient can come to the daycare. So we have to have the definite routes or the marks from the OPD to transfer the patient to the IPD, or from ED to IPD, or from daycare to IPD, dedicated routes. And the size and type of door opening. Sometimes what we have seen is basically the turning radius of a bed. A bed is basically a 6 feet or 6.5 feet long. When it turns along the curvature, when sometimes what we have seen is the bed is moving in the gallery, and later you have to turn the bed 90 degree or 180 degree or 120 degree whatsoever. So the turning radius is the critical point here. For the turning radius, basically for the 6 and 5 feet long bed, we have the 20 feet of the turning radius, approximately or roughly basically 3 times of the length of the bed. So the doors which are basically openable, or the two side doors opening outside, is never permissible. Door should be opening inside, or the better practice is having the sliding doors. Basically to overcome the turning radius of the 20 feet or the 22 feet, we can have the openable doors side by side instead of doors opening outside. Outside opening doors are basically not permitted nowadays, but a better option is the doors opening inside. आउटसाइड वाला तो वो कॉरिडोर को ब्लॉक कर लेगा, तो टर्निंग रेडियस हो ही नहीं पाएगी उसके लिए. Then the types of floor services and the transition needed to facilitate safe and effective use of patient handling and movement of equipment. Basically the type of floor services. Uh, in the initial days when the hospital was planned in the basically in the urban areas or the semi-urban areas, there is a tradition that use the Italian marble or the Italian floorings or Sangmarmar type of the structures basically. But when we use the as the hospital is the basically the infection prone area, for the infection control purposes you have to use some kind of chemicals. Either you have to use the betadine type of structure or the Cyanox or the oxidative type of the chemicals which can disinfect the floor area basically. So when you use the chemicals on these kind of Italian marblings or the Sangmarmar or another type of Kota stone whatsoever it is, so there is staining on them. So the floor material should be of that kind that is stain free and one is non-porous. Okay, otherwise the water will permeate inside the stone or the inside the floor material and keep them damp. And the dampness is the basically the welcome for the fungi or the bacteria or the virus. There is basically the multiplication sites for them. So we have to have the non-porous and the cleanable and non-stainable type of the floor surfaces. Then the coordination of patient handling and movement equipment installation. Basically, according to the mechanical electricity load, we can plan our infrastructure later on. Then the storage spaces. What we have seen in the wards or the other ICU or OTs, there is no provision for the storage spaces. Basically, majority of the equipment needs some installations along some accessories. For example, we have to take the ventilator. Ventilator is one, but for each and every patient, we have to use the separate circuit, and separate circuit is huge. Basically, 2 square meter of the need 2 square meter or 2.5 square meter of the storage area for a one circuit. And if your ICU is of the 20 beds, and your turnover is the daily or the alternate day patient is turned over from the ICU, either a patient got expired or the shifted to the HDU or the ICU or downgraded from there, then we need the huge storage requirement. Right now, in the previously we have basically experienced in the hospital storage, there is a storage constraint. We are seeing in the main hospital already, there is storage constraint, and for the future need, we have to plan the storage area accordingly. Then the impact of the installation and the use of patient handling and movement equipment. Basically, the equipment had to be shiftable. Right now, you are fitting any equipment in the basement or the ground floor, but as per your requirement changes, you have to move the equipment to the another floor or the another side. So there should be the friendliness to the shifting of the equipment. Then impact of installation and use of patient handling and movement of aesthetics basically. Then the infection control risk mitigation requirements. Infection control is basically this is the core in the hospital that the infection should be controlled. If the patient is coming to the hospital, he is well assured that he is not getting any nosocomial or the hospital infection in the hospital. We have to assure the patient that his infection will be treated, but he is not getting the cross infection from the another patient. So the hospital should be planned accordingly. There is adequate air circulations, adequate infection control practices to be followed. How the infection control practices will be followed basically is the question here is that you have to use the surfaces which are smooth, which are easily cleanable, which are easily maintainable. Then the AHU planning, air handling unit planning basically. A majority of the infections which we have seen over the period of time are basically the spreading through the route of air. These are the basically communicable disease, including the TB or the recently basically the COVID or whatsoever it is. These are spread through the air. So if we are planning an air handling unit which is separate for that area and only used in that area, or basically the compartmentization of the patients, if the same type of disease character can be compartment in the one area or one ward or one HDU or one 6-bed or 8-bed units, then we can plan AHU air handling unit accordingly for it. Then the site selection for the hospital. This is basically the what kind of plot we are planning for the hospital building. It should not be the liquefiable ground. Basically, it should be a solid ground which is not filled previously by water or by basically sometimes we have seen in the sometimes the hospital are planned in the village periphery or the outskirts of the district where previously there was a pond, and later they fill the pond with the soil and they allot this land to the hospital. And when the hospital or other building who whatsoever is built on that ground, they will collapse over a period of time. Then the hill slopes. Hill slopes are basically unstable, so the hospital should not be planned there. Flood prone areas and adjoining unsafe building or structures. Basically, if the hospital is surrounded by the unsafe buildings, so at the time of disaster, when the earthquake come or another basically the disaster came, surrounding buildings may collapse on the hospital. So basically, hospital is a one building which should be collapsed last or should not be collapsed in any of the basically hard times or the in any of the hard times. Basically, it needs hospital is needed mostly, and the first most thing hospital is needed in the community at the time of disaster. So at the time of disaster, every patient has to run to the hospital, and the hospital is self collapsed. Then where the patient has to go? Then the poor accessibility in the post-disaster situation is the hospital is basically situated in an area which is surrounded by the basically the unsafe buildings. So unsafe building might collapse on the road. So there is poor accessibility to the hospital. So we have to plan accordingly. Then there are some laws which are governing the commissioning. These are the laws which are directly related to the commissioning, not to the basically the general day-to-day or the operational activities of the hospital. Basically these are the Atomic Energy Act, which is applicable to the if you are planning to have the PET scan, then we have to abide to the Atomic Energy Act. Then if we are planning to have the lifts, by and large, every hospital nowadays having the lift. Basically, the critical and the non-critical patient has to go through the lift, shifted. Either OPD patient might go through the escalators or the staircases, but the critical patient has to shift to the by the lift. So we have to abide accordingly with the Delhi lift rules or the whatsoever the state lift rules. Then the Delhi lifts and escalator bill and the Companies Act have to be registered. Hospital is registered accordingly in the Company Act. Then the electricity rules, we have to declare basically the all our electricity requirement we have calculated per bed wise. The rough factor is the 3 to 5 kilowatt hours per bed. So we have to calculate accordingly and declare. If there is a need of the substation to be put or having the 33 kV line directly to the hospital or the hotline, then we can think accordingly as per that rule within the time frame. Then the Delhi Fire Services, Delhi Fire Prevention and Fire Safety Act, we have to abide to the fire services norm. Right now, the fire services norm in the Delhi does not provide the critical patient above the 30-meter height. So basically, above the 30 meter, you cannot put a critical patient. Which means if I say you in the a floor is approximately 4.5 meter high. So after the sixth floor, you can't put a critical patient. If a floor is basically this floor is the 4.5 meter height. So within 30 meters there is a sixth floor. So you can't put right now on the critical patient, or you can't make OTs or ICU on the seventh floor. You have to put all the critical patient within 30 meters. These are the new guidelines which are coming just 3 years back. Right now we have all the OTs and ICU on the 8th floor. These are just 3 years back after the fire in the AIIMS only. Then you have to abide to the Electricity Act or the Electricity Rule, or basically a National Building Act. We have to comply with the Disaster Management Act, Radiation Protection and the Society Registration Act. Then the land use, and the land use should be according to the Urban Land Act. Then the Indian Boilers Act. Basically these acts are very old. Right now the Indian Boilers Act is basically for the steam use in the hospitals. Right now we are not using any kind of steam in the modern hospitals. These are for the CSSDs or the laundries. Nowadays the laundries are automated and CSSD are automated. They are not requiring the external steam support. They are well generated for their own machine. Then the hospital to be registered in the Clinical Establishment Act. So planning of a hospital. So how a hospital is planned, there is various consultancies which charge huge for basically a planning aspect of the hospital bed. So right now we start the planning of the hospital beds. How much big hospital or how many bedded hospital we have to plan. So this is an exercise, we will start it, and this is for a district hospital. So called a hospital is placed in the district which having a population of, let's suppose the population of 1 million. There's a 10 lakh population in that district, and there is a already criteria that the annual rate of admission in that district is 1 per 50 population. So So the total number of admissions per year will be 10 lakh divided by 50. This is the 20,000. And if we suppose the average length of stay in the hospital for a patient, it is around 3 to 5 days or 7 days. We have to check with the basically the vicinity of the or the territory of the area we are planning, either the urban or the rural. Basically, in the rural setup, there is the communicable disease which are more, but in the urban setup there is the non-communicable disease which are more. And over a period of time, basically what is observed that the non-communicable disease taking the larger average length of stay, as per despite the average length of stay is more in the urban setup, because the non-communicable disease which is taking the major chunk of stay. So the bed days available is the 20,000 into 5 is the 1 lakh. If we are assuming the bed occupancy is the 100%, then we have to divide the 365, divide this 1 lakh by the 365. So we have to come to the conclusion that the 275 beds hospital is needed. And this is the first hospital. You have to think about if another hospital in that vicinity, or what kind of services you are. This is for the moderate to critical. What kind of services you are providing is the basically the primary health services, secondary health services, or the tertiary health services. If you are planning to have the tertiary health services, you have to basically compare yourself with your competitors or with another hospital in the vicinity. If there is another hospital in the vicinity, you have to check accordingly. The deciding factor is the scope of services you are offering. If you are offering the same scope of services which your competitor or the hospital next door is already servicing, then you might have the bed size to the decreasing level. So you have to check the scope of services. Fine. So by this formula, we can have the bed calculated for the any kind of hospital. Then the plot size. If we are planning a 100-bed hospital, we have to have the around 0.5 hectare of the plot size, and for the up to 101 to 200 beds, we have to have the 0.5 hectare to 1 hectare. Then above 500 beds, it's basically the 6.5 hectare, 4.5 hectare for the clinical area, and 2 hectare for the residential. Then for the general hospital, how the total built up area is calculated for an hospital. For one bed, we have to take around 100 square meter of area. So for a general hospital, we have take the around 80 to 85 square meter area, and for the teaching hospital or the specialty or the super specialty hospital, we have to take the 100 to the 120 square meter of area. We right now concluded a 4,000 bedded hospital for the AIIMS in the master plan, and we have taken this to the 150 square meter of area, because we are offering the quaternary and the super specialty care, and we are taken a factor of 142 square meter exactly. Then how the OTs are planned. One OT is planned for the 50 general inpatient beds. These general inpatient beds including the medical beds, and one OT for every 25 surgical beds. Basically all the surgical patients are needing an OT. So the half of the patients are recommended for one OT. So 25 surgical beds, we have to have one OT. And ICU bed are generally the 5 to 10%. But right now, nowadays, what is observed that there is a scarcity of the ICU beds. Or basically, in my personal experience right now, the purchasing power of the patients are increasing, and most of the bill are claimed through the TPAs or the insurance company. So every patient or their attendants requests a doctor to provide a critical care bed or the HDU bed. Basically, there is a general perception that there is more care in the critical care beds or the HDU bed as compared to the general ward. So we have to factor that we have the additional ICU beds. Then the floor space for each ICU bed is the 25 to 30 square meter, and floor space for the pediatric ICU bed is a 10 to 12 square meter. And the floor space for the HDU is in between the general bed or the ICU bed is the 20 to 25 square meter per bed. So now the bed space is the 7 square meter per bed. So 7 square meter, basically the 7 meter in the length and 7 meter in the breadth. So we can have the access to the bedside of the patient and along with the leg side of the patient. For normal, madam. ICU and HDU. Then the clearances at the foot end of the bed is 1.2 meters. So at the time of need, if we have to assess the head end of the patient, we can push the bed to the leg side. Then the minimum area of aperture, basically we have to have the cross ventilation in the room. Uh, right now, nowadays, basically we have centrally air conditioned buildings. So this is of no use in the centrally air conditioned building. But for the medium hospital, which is sponsored by the government or basically the government funding, which are not having the centrally AC, so we have to have the apertures in the building. So 25% of the floor area for the window, if the window is planned on the same side of the door. So the door is on that side, and we are planning a window to have the 20% of this floor on the wall along the door. If we are having the cross ventilation and we are planning a window on another side, then we can have the 15% of that. Because if the door and the window are on opposite side, there is a possibility, there is a better chances of the cross circulation. So we can have a lower, basically 5% relaxation norms for this. Then now the infrastructure guidelines. Anything in the basically the hospital planning or any queries, any doubts, any suggestions regarding the planning? Sorry. हाँ बताओ क्या इसको अभी आगे कवर कर रहे हैं फॉल सीलिंग को फायर में कवर करेंगे उसी में उसका बेसिक एस्पेक्ट बिलेंगे नहीं प्रॉब्लम नहीं है बेसिकली वी हैव टू हैव द फॉल सीलिंग्स मैडम इसको अभी फायर में कवर करते हैं फिर अभी सीलिंग्स को मैम दिस बिल्डिंग इज which building yes for the mother child block and the surgical blocks these are followed but the main hospital or the H building these are not basically these are very old buildings in the surgical and the MCH block these are followed क्या कह रहे हैं आप? एक एक करके क्या कह रहे हो No, madam, old building should be demolished if they have lived their life. The expected life of a building is 50 years, and these buildings have lived their life already. So that's now, right now, the master plan of AIIMS is coming, and all the old building will be demolished over a period of time, and the new building will be constructed. And then, yes.
The new MCH block, we have seen many times. I think the space and so on is not what you have explained. It's totally very, very frustrating just to go and work there.
होगा मैडम बिल्कुल होगा because actually that when you are planning a ward of the 30 beds and over a period of time when it is converted to the madam when you are planning the basically the ward is of the 30 beds but over the period during the commissioning it got converted to 45 beds then the whole planning collapsed and there are some administrative constraints you are planned for a 30 beds and over a period that convert to the 45 beds then you have all the planning now suddenly collapse
Physically, I have seen.
we have also seen madam
There's no distance between the
हाँ नहीं होगा नहीं
Because the whole infrastructure, I think it's not only the patients.
whole infrastructure need basic overall madam basic overall or infrastructure is needed that's why master plan is coming
These kind of classes when we don't apply in our.
so let's start the infrastructure guideline for the prevention of disaster in hospitals the infrastructure guidelines for the prevention of disaster there are specification laid down by the NDMA or the basically the DDMA National Disaster Management Authority and the Delhi Disaster Management Authority we have to abide to the both and these rules are for the newer buildings and already existing buildings so hospital is coming in the critical buildings which have to have stand at the time of disaster hospital is the last building or building no one is expected to collapse at the time of disaster basically because all the patients at the time of disaster has to run to the hospital. The experience at the time of Bhuj attack, which the basically our Prime Minister also mentioned that at the time of earthquake in the Bhuj, hospital building collapsed. There are many visuals or the many photographs that we have used there. And so at the time of maximum demand, the hospital building is collapsed. So where to go? where to go. Or these norms are basically coming after that. Before that, there was no norms for the hospital. So the component of a hospital building, there are two components. One is the structural element, second is the non-structural element. These are not just for the hospital building, this for the every building. Structural building is structural element are basically the pillars, beams and columns. यहाँ ये फॉल सीलिंग और ये फॉल्स हुई है, यहाँ स्ट्रक्चर बीम्स और कॉलम नहीं दिखेंगे अभी शायद. तो बेसिकली द columns are the central part of the pillars are the central part of the building. हाँ ये होगा मैडम, यही होगा. ये है, फिर ये है, फिर basically these are the load bearing structures. So these are the load bearing structure, and I have to mention that the structure elements, there are components of building which resist load imposed by the external load effects, and there is a non-structural element. Non-structural elements are basically these chairs, tables, false ceilings. So there are two components, and basically the structural elements are the critical elements for a building. These are the structural elements. Cursor is not. These are the structural elements, basically the column, beams, and pillars. And the non-structural elements are the basically the other accessories in the room, the table, almirah, or the false ceiling. So in the critical buildings, the collapse of the non-structural element is permissible. False ceiling can basically the collapse, but it is repairable, or we can remove the false ceiling within half an hour. But the structural element should not get collapsed, or even the cracks in the structural elements are not allowed. So the classification of building from the disaster point of view. So basically there is a university or the campus. All the buildings are not serving the patients. So the overall university or the overall campus is divided into two: critical buildings and non-critical buildings. Critical buildings is basically the H block where we serve the patients, and the non-clinical or the other buildings are basically the administrative buildings, which are not so critical but might require at the time of disaster. Basically, if you have to run the show of 3,000 patients from the clinical building, so you must have the administrative support from the administrative building to run that show. You have to get the procurement, you have to get the storage, you have to get the roster meeting and the other sport activities. So all the university or all the campus should not collapse, but critical units, there is a mandate that critical units must not collapse. There is the possibility that the other units in the hospital, including the administrative block or the storage part, might collapse, but there is no certain standards. But there is a mandate that the critical units must not collapse. That the critical unit structural damage commensurate with the immediate occupancy. That after a disaster, critical units have to be immediately occupied. And for the other units, structural damage commensurate with the life safety performance level is permitted. And structural elements sustain reasonable structural damage but do not lead to structural collapse. So what kind of material we have to use in the building? The basic material for the construction of the structural system of the new hospital building shall not be reinforced. Basically, we have to use the reinforced material. Previously, we are making the hospital with the brick or the brick, sands or cement type of structure. Right now, we are not making any of the hospital with these kind of with 6 cells. Or we have to use the reinforced material. Reinforced material, basically the same brick we are using it to make our house, or the previously we are making the hospital. Right now, same brick has to be reinforced. Reinforce, how they will reinforce? They have to reinforce by mixing the concrete in them. Previously, we are using the bricks which are made from the soils or the components of the coal. Right now, we are using the bricks which are made from the concrete or the reinforced material. The structural wall shall be made of the reinforced concrete and providing in the slack bay running through the full height of the building. Basically, this pillar has to go from the basement to the topmost 9th floor. Then the total cross-sectional area of the RC structure wall shall not be less than 4% of the plinth area. Now what is written in the new rules is that these two walls, cursor, these two walls, one is this or and second is this, or one is this and second is this. So during the basically the construction phase of the hospital, these two basically these two pillars, one is this and second is this, or one is this or second is this. Basically, these are the 90-degree to each other. These are the 4% of the total area. So we have to build a huge pillars or huge columns at the time of construction of the building. If this is the basically the 100 square meter of the area of the floor, we have to build the 4 square meter wide or 4 square meter basically the dimension of this pillar and this pillar. Then for the prevention of the ill effects on the building during the earthquake, there are the base isolation system. These are effective in the strong earthquake situations. Right now, the hospital in which are in the earthquake prone zones, basically in the seismic zone 4 and seismic zone 4 and 5, not in 3. Seismic zone 4 and 5 are using this, not in our country, but in Japan. Basically, Japan is more prone to the earthquakes. They are using this technique. The base isolation system is adopted in the seismic zone 4 or 5 and minimizing the basically the risk of shaking of the building. How the base isolation system is working right now, I will explain you. Basically, these are the hard springs or spring-like structures which are basically the elastic in nature, which are put in the basically what we are called is the nave of a building. So these spring or the elastic structures are put in these in the continuity. So when the earthquake comes, how the earthquake waves are come horizontally to the basically surface. If this come horizontally, then these are the springs or the elastic material which take the major load for the vibrations, and the same vibrations are not propelled to the building. So building gets safe. If these are not in the basically the face-based structure, all the vibrations are transferred to the building and building might collapse. So the base isolator system is there in some of the hospital in Japan. No, madam. No. Basically, these are very costly, and the engineering require a budget in the tune of 50% of that. If you are planning a hospital of the 100 crores, you have to have the 50 crore budget for this only.
Easier also is supposed to be.
Basically, madam, we are not in the zone 5. Basically, some of the hospitals in the Tamil Nadu and Andhra Pradesh, which are basically on the coastal regions, are in the zone 4 or 5. But they are not using this kind of technology. They are making basically a jugaad kind of thing, that they are not allowing the more than 2-story building on the periphery or the coastal regions. So high-rise buildings are not permissible. They are giving only the permission for the 15 meters to the 20 meters height. Then the following structure items are prohibited: that the flat slab walls, pre-stretched floor area, precast construction, large cantilever structures, and the long span structure. Basically, large cantilever structure are you might have seen on the porch where the car or the vehicle are entered in the building. There is large structure which are cantilevered to the beams or columns. So if the building get vibrated, this cantilever or the large cantilever structure might fall. And unreinforced masonry buildings. So the specific consideration for the fire. First is the compartmentation. We have to think for the compartmentation so that the fire, if arises in a building, should be compartmentalized or should be localized. It is not spreading to other areas. So how the compartmentalization is made? First is the fire resistant wall. We are using the fire resistant wall in the patient care areas or in the normal building. These are in the tune of 1 hour to the 1.5 hour. Fire cannot pass within 1 hour from the dead door. And the fire resistant doors of approved rating, pressurized lobby, corridor, and staircases. The concept of pressurized lobby, corridor, and staircases is what is observed in the case of fire, that the majority of the patient doesn't die of the fire. They have died due to suffocation from the smoke. If your lobby, corridor, or staircase are pressurized, positive pressure, then the smoke cannot come to the lobby. Inside is the positive. Same concept we are following in the OTs, or the positive pressure is inside and negative pressure, or the more pressure is inside. If the more pressure inside, the smoke can't come inside the lobby or corridor. So the smoke can't come. Majority of the casualties can be evoked. Then the pressurized shaft. Shaft is basically the area between two floors or the multiple floors where all the risers or all the pipes are going. If that shaft is positive pressurized, then the basically smoke can't go from one floor to another. Then there is uh, a construction or refuse area over and above the 25 meters of the construction, and independent ventilation system for an area, including the fire dampeners, automatic sprinkler system, automatic detection system. These can detect heat or smoke, manual call points, first aid areas, firefighting appliances, firefighting alarms, alternate power supply, PA system signage, and the fire exit drills and orders. Just things. सीलिंग का डिस्कस कर लेते हैं मैडम, आप क्या पूछना चाह रहे थे उसके लिए? Let me explain you. There are multiple services run in a hospital or in any building. If you are seeing that, what is between the basically the linter part of the and the between linter and the false ceiling, what is going? There is approximately 90 to 100 pipes or 90 to 100 services is going through it. Let me explain you. First is the water pipes. जो जितने भी स्प्रिंकलर्स हैं, इनका जो पानी की पाइप्स हैं वो हैं. फिर इलेक्ट्रिसिटी सप्लाई की पाइप्स हैं, और उसके बाद फिर आपके जितनी नेट की कनेक्टिविटी आती है वो सारी यहीं से हैं. सीवरेज ड्रेनेज सिस्टम की पाइप्स यहीं से होंगी, इलेक्ट्रिसिटी वाली सारी यहीं से हैं, और हाँ एसी डक्ट सारी आपकी यहीं से है. तो बेसिकली अगर आप ये नहीं करोगे तो यू आर क्रिएटिंग द रो एरियाज फॉर स्प्रेडिंग ऑफ इन्फेक्शन. दीज आर समवट कॉल्ड द बेसिकली ये स्मूथ हैं, फिक्स हैं. बेसिकली आप इसको उतार के धो भी सकते हो अगर धोना चाहो तो, लेकिन धोता हमारे कोई भी नहीं है. फॉल सीलिंग नहीं करेंगे तो बेसिकली वी आर क्रिएटिंग वो सिस्टम का फेलियर है मैडम के इसमें अगर आता है तो. वो सिस्टम का फेलियर है मैडम कि आप प्रिवेंटिव आपकी मेंटेनेंस अगर नहीं होती है, या फिर इसमें चूहा या बिल्ली घूमती है तो घूमते हैं ना इसमें. लेकिन आई कैन अंडरस्टैंड मैडम, आई कैन अंडरस्टैंड.
किसी इलेक्ट्रिसिटी को बोलो, वो बोलेगा इंटरनेट का फायर, वो क्लीन करेगा. फायर वाला बोलेगा या इलेक्ट्रिक वाला बोलेगा पानी का.
एडमिनिस्ट्रेटिव रीजन्स. एक्चुअली होता क्या है ना मैडम, और एक्चुअली होता क्या है कि ओवर ए पीरियड ऑफ टाइम क्या होता है कि जब इसकी रिपेयर होती है तो जहाँ पे पाइप ओरिजिनेट होती है, जहाँ पे यानी बेसिकली जो हार्ड एरिया से होती है, तो वहाँ उसको सील एग्जैक्टली नहीं किया जाता जो कि ऑब्जर्व किया है. और वो सील अगर नहीं होगी तो उसमें चूहा घूमेगा ही मैडम सर. नहीं मैडम, मैं वही कह रहा हूँ कि जब इसकी रिपेयर होती है तब ये ध्यान नहीं दिया जाता कि बेसिकली इसको सील इम्प्रॉपर सीलिंग होती है तब उस टाइम पे. वहीं पे फिर चूहा आता है, चूहे के पीछे बिल्ली आती है, बिल्ली के पीछे शेर आ जाता है, ऐसे वाला होता है ना. नहीं है मैडम, प्रॉब्लम्स है वो, और ये सोल्व हो सकती है जब आप वहाँ पे मेंटेनेंस हो रही हो तो हम उसको सुपरवाइज करें. नहीं ये सॉल्व हो सकती है मैडम, बिकॉज एट द टाइम ऑफ मेंटेनेंस वी शुड सुपरवाइज इट. Sorry madam.
For 17 years, we came to realize that AC duct also can be open and clean the whole thoroughly. After 17 years, what? You can just see, no one was there.
एसी क्लीनिंग या क्लीनिंग होती है ईयरली एनुअल मेंटेनेंस के टाइम जब हम लाते हैं तो एक दूसरे का होता है, दूसरा तीसरे का होता है. अल्टीमेटली वो कोई भी नहीं होता है. जब इतना होता है कि बॉक्स कुछ भी नहीं होता, वैसे की वैसे बस थोड़ा जो करने वाली टाइल्स है क्लीनिंग है वो वॉश हो जाती है बस खत्म हो जाती है। अगर जो इंटरनेट पे पैसा मिट्टी जाला थोड़ा बहुत इंटरवा देते हैं।
एक्चुअली हमारे सिस्टम ही यही है ना मैडम कि इंटरनेट की तार है तो कंप्यूटर फैसिलिटी वाला उसको साफ करेगा, है ना, और पानी की है तो उसको सिविल वाला करेगा। सिस्टम ठीक नहीं है उसके लिए, यू हैव टू मेक ए सिस्टम मैडम। और नई बिल्डिंग्स पे सारी सर्विसेज आउटसोर्स है तो सिंगल पर्सन करता है उसे, उसको कोई मतलब नहीं है तार किसकी है।
But it's our system only.
They are definitely improved, madam. Right now we have seen they are improved.
Even I was surprised.
Sorry, madam. Madam, basically there are two things for the maintenance. One is the owner, and one is the basically the laborer. Laborer is from the civil side, but the owner of that building is the ANS or the DNS or the sister in charge of that ward, madam. Basically, just a simple example, madam. What happened if your own home is leaking? Who is responsible? One is the owner of that house. One is the owner of that house, and secondly is the civil engineer, madam. Yes, basically both are the party. Ma'am, this should be basically the annual maintenance program, and we have in the institute annual maintenance program. I think you must be aware of.
Ma'am, civil engineer has no input in maintenance. Just one thing. It's very, very bizarre. I think I have addressed so many times about it.
In the last meeting also we interacted regarding the same, na?
That the civil maintenance is totally, because of them, we can't function in such a way like we want.
एक्चुअली मैडम मेंटेनेंस के लिए लूप क्लोजर सिस्टम नहीं है आपके पास, टर्नअराउंड टाइम मापने का तरीका नहीं है, टीएटी आप कभी मेजर नहीं करते। आज आपने कंप्लेंट किया, किसी को नहीं पता कब सोल्व हुई है और कितना टाइम लगा है। आप उसको एक आपने इतने सारे 28 रजिस्टर आपने एक काउंटर पे रखे हैं, एक रजिस्टर उसका भी होगा जरूर, है ना, और आप उसको एक पब्लिक डोमेन में डालो कि कितना टर्नअराउंड टाइम है, तो कैसे नहीं होगा हमने। हाँ मैम, उसी के लिए मैडम अभी आईटी पॉलिसी आ रही है। मे बी आई मेट यू
Yes,
फॉर द
sir.
आईटी इंटरेक्शन है, आईटी फीडबैक।
Last month. We have a very serious problem there in the auto cubicles में infection हो गया है, ठीक है। इसी टाइम से all the duty officer, administrator, everyone, all the consultants were involved. With me and my senior in charge. Every day we keep writing to them this and that. Letter is being written. Everything is done till yesterday.
कहाँ का है, कहाँ का?
It's in the files.
कर लेंगे बात मैडम, आपका कर लेंगे इसके रिगार्डिंग।
Last time also you said that you will come and see that कोई आया नहीं what.
आएगा मैडम, आएगा।
It's something most of the time, ma'am, we were so frustrated. Whether you have to be totally.
चलो अभी टॉपिक का देख लेते हैं मैडम। प्लानिंग में अगर कुछ है तो आप वो बताएं, ये तो एंडलेस है, ये तो मेरे को भी 8 साल हो गए सुनते हुए। तो
नहीं मिलता है या बैठने
नहीं, गॉट इट मैडम। प्लानिंग के रिगार्डिंग अगर कुछ क्वेश्चन है तो हम वो डिस्कस कर लेते हैं।
Should be here at this kind of topic.
सर को पता होता है मैडम, सर को क्यों नहीं पता होगा? जब मेरे को पता है तो सर को क्यों नहीं पता होगा? उन्होंने तो पूरी लाइफ ही यहाँ पे रखा है सर, और जो हमें पता होता है सर को इमीडिएटली पता होता है। कुछ और क्वेश्चंस, कुछ और इंटरेक्टिव या कुछ और करना चाहिए प्लानिंग के रिगार्डिंग?
Sir, just the ICU bed ratio, we are not taking that topic.
Which bed?
ICU ratio. Patients.
We have taken for the hospital, madam, 5 to 10% basically. Yes. Sorry, madam.
I give all the place.
ऐसा कुछ स्टैंडर्ड नहीं होता मैडम, आईसीयू वॉल की थिकनेस का कुछ स्टैंडर्ड। Previously the walls were there. Previously, right now we are using basically the structured or the pre-engineered wood. तो कोई थिकनेस होती नहीं। आज की डेट में तो आप किसी भी आईसीयू में देखोगे जो बैरिकेशन होता है, बेसिकली वॉल्स कहाँ होती हैं एक बिल्डिंग में? आज की डेट में वॉल्स होती है बिल्डिंग के पेरीफ्री में, बीच में तो सारा मॉड्यूलर स्ट्रक्चर है। आज की जो बिल्डिंग्स है वो सारी पिलर्स पे हैं, और उसकी जो पेरीफ्री है वो आपकी सॉलिड कंक्रीट या रीइंफोर्स्ड कंक्रीट की है। बीच की तो जितनी भी आपकी सारी इंजीनियर्ड वुड या फिर इंजीनियर्ड मटेरियल की होती है। कोई वॉल तो बीच में आप कंस्ट्रक्ट ही नहीं करते, तो थिकनेस वाला तो कुछ वो है ही नहीं उसका। लेकिन जो अभी न्यू आर की ओपीडी में जब प्लानिंग और डिजाइनिंग हुई थी तो बट वी आर सेइंग देयर दैट द जो बीच की जो वॉल्स हैं वो प्री फैब्रिकेटेड हैं, बड़ी पतली हैं, तो उसके ऊपर आप मॉनिटर नहीं लगा सकते, है ना, उसके ऊपर आप स्क्रीन या टीवी नहीं लगा सकते। ये साथ में जो ओपीडी कर रहा है और इस साइड आपकी ओपीडी है, दोनों में आवाज़ आ रही होती है क्योंकि वो बहुत पतली होती है। तो उसका भी है कि आप साउंड प्रूफिंग का अगर आप लेना चाहें तो उसमें साउंड प्रूफिंग का कर सकते हैं, डैम्पनर्स होते हैं, वॉइस डैम्पनर्स बेसिकली, या वाइब्रेशन डैम्पनर्स, वी कैन यूज देम। लेकिन ऐसी कोई गाइडलाइंस ऐसी नहीं है कि इतनी थिक हो, वो एज पर कन्वीनियंस और एज पर योर रिक्वायरमेंट वो उसमें कन्वर्ट। This one, na? This is basically for the, this is the formula to calculate how much bed we have to cater for that area. If that basically we are planning a hospital in a district is having the 10 lakh population, and we have to make the assumption that the 50 that the one person in the 50 basically or 2 in 100 require the admission over a period of 1 year, and the average length of stay is might be different from the 3 days to 7 days or 10 days, but sir, the scope of services or the facility you are giving. So the total number of admission per year is basically the 10 lakh divided by 50, and the 20,000, and the bed days is commensurate according to the services you are offering. If you are offering the surgical beds, there might be the ALOS is the 7 days to 8 days. If you are serving the medical patients or the daycare, for the daycare, instead of 5 days, will come the one. If you are coming the general infection days is 3 to 4 days. Basically, the 5 is the mean of the medical and the surgical. It is the basically general rate criteria or the standard that we have to take the 1 per 50 and ALOS is 5. So from that, we have to calculate the bed days, which is coming to the tune of 1 lakh. And if you are running on the 100% occupancy or 365 days of the year, then we might require 250 to 300 beds. These are general, basically a very broad calculation of beds. It depends on your vicinity. If you are a corporate hospital and you have a hospital next to you, which is already catering the 500 beds, then how can you operate? You have to have the different scope of services. If that hospital is offering the basically a surgical treatment or the daycare treatment, you have to have the medical treatment. Or if they are using the primary or the secondary level of care, you have to have the tertiary or the quaternary level of care. You have to be distinguished from the vicinity or the competitor or the so-called in the society. Or apart from that, the catchment of you, if you have to target the urban population or the rural population, or what kind of population you are catering. You are catering to the cash patients, you are catering to the TPA patients, you are catering to the BPL patient. It's accordingly and commensurate to the scope of the services and the level of services you are providing. Fine. Thank you. Thank you.
Thank you so much.
Thank you so much, sir, on sharing valuable information on hospital building norms and infrastructure guidelines. So far, sir has discussed about guiding principles, various architectural factors, and structural accommodations that have to be kept in mind to meet the current and future needs. Sir has also emphasized the importance of air handling unit for adequate air circulation to prevent nosocomial infection. Now, I would like to request Dr. Shashi Mawar to give token of appreciation to Dr. Arun.
So
Now moving to the next session, I welcome Mr. Deepak V. Agarkhed. He is Associate Vice President at Sakra World Hospital, Bangalore, Karnataka. He is going to enlighten us on the topic Designing Emergency Department, ICU and wards. I welcome you, sir.
Sir, please unmute yourself. Sir, we are still not able to hear you. Please unmute yourself. So you might be logged in from two devices. That is the reason the voice is echoing. So just log in only from one device.